Is it too?
Okay, I think we are right on the minute here. So we're going to go ahead and get started. And seem to be in focus up there. Let's just get ourselves here. Okay, so. Or you want to start us out?
Sure. So let's do a little bit of hyperkeratosis.
So you got hyperkeratosis.
The epidermis looks effaced. There's some metatic vessels there.
So is it entirely effaced, or are there areas of acanthosis as well? So they're kind of both, right?
Yes, sir. And then there's that elastosis.
And you commented on the ectasia, elastosis, and anything curious about the elastosis?
It's a little bit bluer.
And
Deeper.
yeah, exactly. So it follows the follicular structures. So you have vertically oriented elastosis, which is something that you don't get typically with solar elastosis. You don't get it in hair follicles, vertically oriented. Speaking of hair follicles, where are they? Gone. So adnexal structure is largely gone. And if we go a little higher, exactly, you have very large stellate, irregular fibroblasts that are good for radiation fibroblasts. So this is radiation dermatitis. So to summarize again, hyperkeratosis, alternating atrophy and acanthosis of the epidermis, homogenization of the superficial dermis, prominent elastosis that looks like solar elastosis, except that it also extends down hair follicles, loss of adnexal structures, and presence of radiation fibroblasts. So how would it differ from superficial morphia? So in morphia, you get superficial homogenization, but you definitely get sclerosis of the deeper dermis as well, but you lack the radiation fibroblasts, and you lack the vertically oriented elastosis in the hair follicles. And how would it differ from lichen sclerosis?
There's no lymphoid band.
Yeah, so LS always has a lymphoid band. It may be sparse, but there's always some kind of lymphoid band present that tends to be absent both in radiation and in superficial morphia. The vascular ectasia is kind of unique to radiation dermatitis. You don't see that either in morphia or LSNA. And then LSNA doesn't have the radiation fibroblasts, the vertically oriented elastosis, so you typically can tell them apart for all of those various reasons. Okay, very good. How about next one? Tell me about this big fibrotic nodule.
So it looks like there is some like bubblegum collagen in there as well.
There is keloid collagen in the center. So what kind of a lesion contains keloid collagen?
A keloid.
A keloid, shockingly enough. Right. So you have bubblegummy collagen in a background that is otherwise whorls of myofibroblastic cells similar to a hypertrophic scar.
So we have a pretty square punch.
Pretty square punch.
Nice bright red collagen that's pretty compact. Looks like the adnexal structures look trapped. Gives me the sense of morphia.
So it's a very squared off punch. You have superficial homogenization, very much like lichen sclerosis. Do you see any lymphoid band at all?
Mm-mm.
Not really. right? And adnexal structures, unlike radiation, are present, just trapped. And you don't have the vascular ectasia, nor do you have the prominent elastosis of radiation dermatitis. That would be pretty good for morphia.
So it's the deep punch biopsy, and I think the upper part and middle part of the dermis look pretty normal, and then in the deeper part, I think it's a little bit thickening of the septi, and maybe it's even necrosis.
Yeah, certainly lots of fibrin.
Fibrin.
Right,
yeah.
so lots of fibrin, very deep, parallel to the surface, immediately adjacent to the striated muscle.
Yeah, so I was thinking about eosinophilic fasciitis.
So it's certainly the location and
Yeah.
configuration of eosinophilic fasciitis. Where are the eosinophils?
You may not have them even, but
Yeah, it's named for peripheral eosinophilia, so it's named for the blood, right? So where's the eosinophilia? Number 1 in the name, number 2 in the blood.
well, sometimes
Not
you see
reliably in
them.
the tissue. Well, they may be, but it's plus minus in the tissue. What makes the diagnosis is just the location and organization of the lesion. So it tends to be in the area of the fascia, which is immediately adjacent to the striated muscle, parallel to the surface, usually prominent fibrin deposition and a mix of inflammatory cells, very widened fascial structure.
Punch biopsy, square shape, sclerotic dermis, and in the deep fat there is some inflammation, and also the adnexal is trapped. Morphia again.
So morphia again, very well done. It is a very rectangular or square punch. The adnexal structures have no periadnexal fat, which would be normal on trunk and proximal extremity, right? They usually sit surrounded by fat. Here, the collagen goes straight up to the sides of the adnexal structures, so-called adnexal trapping. You have nodular lymphoid infiltrates at the dermal subacute junction, so very good for morphia again. Very good.
Tiny biopsy.
I just read them, right? So,
It looks.
you know, we get what's sent in.
I'm worried about radiation. I don't see the ectatic vessels.
So you definitely see hyperkeratosis. You see some either atrophy or plate-like acanthosis, homogenization of superficial dermis,
Right.
pigment incontinence,
Right.
all things you could see in lichen sclerosis. Your lymphoid band present or absent?
In this piece, it's not there.
In that piece, it's not there. How about in this piece? Maybe a little bit, so kind of undecided, right?
Right.
And then you have no deeper features. So you go back to the clinical, right? You know, this is either LSNA morphia or radiation, and you match it with the clinical, and you got your answer.
And most likely this little specimen is from genital area because they
Well,
were trying to preserve
It is also
as much as
absolutely correct that in the genital region, people tend to be somewhat protective of their genitalia, so the biopsies tend to be smaller and more superficial. That is a correct statement.
Keratin-filled cysts.
Some keratin-filled cysts on fairly sebaceous skin and lots of elastosis, and the
Smoker.
so so-called smokers' comedones or Favre-Rakeschow syndrome, which is a manifestation of chloracne from all the hydrocarbons you're inhaling with the cigarette smoke. And like other forms of chloracne, you can get clear fluid-filled cysts, you can get keratin-filled cysts and comedones, and nodular elastosis. So the other descriptive name, nodular elastosis with cysts and comedones, for smokers' blackheads, lots of names for them.
Small shave of a papule.
Small shave of either a papule or something that was kind of pinched up with forceps. Could be either way. Looks like there's a little crush artifact. The cells are a little bit dark and spindled, like maybe someone got a little over-enthusiastic with their forceps.
It's in a lot of this pink material.
And there is some homogenization of pink collagen in the superficial dermis. And below that, lymphoid band present, absent, sparse, heavy. So there is a lymphoid band, although it's very sparse, suggesting that this particular example is LSNA. How about location? Any clues in the form of all of these little wisps of smooth muscle?
General area.
It tends to be anogenital skin with all those little wisps of smooth muscle. Very good. And someone who apparently didn't care as much about taking a larger scale sample.
So there's acanthosis of the epidermis, there's hyperkeratosis.
It's this whole big space.
Probably a vessel.
Yeah, that is one ectatic vessel, right?
So it's UV radiation.
And when you go deeper, you can see there is quite a bit of homogenization of the dermis. And fibroblasts, a little weird, right? So, and the history certainly was radiation dermatitis. That was actually something that was paraspinal on the back.
Oh.
And what would you suspect that's related to?
Like a heart cath or some sort
Yeah,
of.
prolonged cardiac catheterization, fluoroscopy-induced radiation, which is always just off the midline on the back.
So papillary dermis looks like it either has edema or it's filled with something. And then below that I see some lymphocytes.
Yeah, so there's certainly dramatic hyperkeratosis,
Yeah.
right? And is the underlying collagen, if this is trunk, is that normal or abnormal?
Guess it's normal.
Pretty much normal, right? You know, that would be normal for trunk. And are there lymphocytes present or absent under the homogenized area?
It's present.
So what are you thinking?
So with all that, maybe LSNA or
Yeah. And so lichen sclerosis, and in this case probably extragenital lichen sclerosis. This is probably lichen sclerosis on the trunk. It lacks the vascular ectasia, retains adnexal structures, so probably not radiation, right? It also doesn't have the elastosis that goes with radiation, at least in chronic radiation. And it has presence of a lymphoid band. There's no sclerosis and loss of space between collagen bundles in the dermis to suggest morphia. So it probably is lichen sclerosis, just extragenital.
So there is inflammatory infiltrate in the middle and deep dermis, and a little bit of sclerosis in the dermis also.
So there is some sclerosis in the dermis. There are infiltrates, and the
yeah.
infiltrates, anything that they're associated with?
Well, it's around hair follicles, so like connective tissue isn't a differential, and
Hair follicle and also eccrine
neck
coil.
eccrine coils,
Yep.
yeah.
So connective tissue disease would be reasonable.
Yeah,
And we
so-
always say connective tissue because you can't tell histologically if it's lupus or dermatomyositis, and sometimes there's even overlap with morphia.
Yeah, so here I don't see any interface or mucin deposition, so I think it can be inflammatory morphia in this case.
So maybe inflammatory
Yeah,
morphia.
but it could be probably any.
And there is a little
Maybe
bit
a
of
little
pigment
bit.
incontinence,
Okay.
so maybe there was some interface change. The history in this case was lupus. Very commonly overlying lupus paniculitis, you have morphia-like sclerosis. In other types of lupus, you'll occasionally see morphia-like sclerosis, and some patients truly have overlap of the connective tissue diseases. So, which is why we often phrase it as connective tissue disease rather than specifying one particular.
The things catch my eye first is those ectatic vessel.
Ectatic vessels, some might say massively ectatic vessels, right?
And elastosis down
And-
beneath.
Elastosis, and is it satisfied with staying where solar elastosis would be, or does it go considerably deeper
I think it goes to the deeper, maybe.
and present within follicular structures? Speaking of which, tell me about the health of the associated follicle.
It is being destroyed.
And it's gone.
So maybe radiation dermatitis.
Radiation, and you see ulceration,
Yeah.
and this is also from the off-center of the mid-back, with a question of morphia. And so what do you think about that? Do you think they were right? Was this morphia?
No.
No, probably more radiation dermatitis, right? And interestingly, the patient we just saw in clinic had been diagnosed as morphia, and then the path had been read as morphia, but on review, probably not morphia, more like radiation.
All right. So another relatively small biopsy. There's hyperkeratosis, homogenization, but no lymphoid band.
So homogenization, but no lymphoid band. I'm so confused. And adnexal structures present or absent?
Present,
How about periadnexal fat?
not so much.
Not so much.
So they're trapped,
How about space between collagen?
not so much.
Yeah, it kind of varies. Here, there's not so much. Other areas, it's a little more preserved. So what do you think?
Possibly morphia.
Yeah, and probably a superficial morphia, because you see much more loss of space between collagen bundles high than you see deep. Right? Probably a nice example of a superficial morphia. Let's see. Let's hit some.
Pretty dense inflammatory cells. Dermis, top, middle, and at the bottom.
Okay.
It's kind of a pale band just underneath that dermis.
Yeah.
Fibrosis.
And is it a tight band or is it kind of spread out?
It's spread out.
And is it
Polka dot.
all lymphocytes or is it lymphocytes, histiocytes, and plasma cells?
Looks like a little bit of all of that.
And is the collagen within the area of the band like the collagen elsewhere, or has it become thin and rope-like?
Thin and rope-like.
Shockingly, it was the second choice for all of the above, right? And so, do you know of anything that would be a broader lymphohistiocytic band with plasma cells and degeneration of collagen to...
Lichen myxodermatosis.
So lichen myxodermatosis, sclera mix, you get new ropey collagen and mixed inflammatory infiltrate, a busy dermis. Does that tend to be top heavy or bottom heavy?
Top heavy.
Lichen myxodermatosis, sclera mix does tend to be top heavy. Usually the inflammatory cells are very sparse, and what you see is just too many fibroblasts with ropey collagen. In this case, it really is a prominent lymphohistiocytic and plasmacytic band, right? So anything else? What if this were acral areas of the body that appeared fairly atrophic, the skin? And it was a very chronic process. So it's kind of an acrodermatitis, and it was chronica, and it was kind of atrophic hands.
Borrelia.
So Borrelia-associated ACA, which is exactly what this is, from the U.S. So we are seeing it more in the U.S. now, being recognized more in the United States.
That's like Dagos bowel perf, right, Dad?
Say it again?
Dagos disease is different.
Different from Dagos disease.
Okay.
So Dagos disease, malignant atrophic papulosis, is maybe is not a peculiar aggressive variant of lupus. It's sometimes antiphospholipid associated. You get the red papules with an ivory white
Right.
atrophic center and go on to have similar lesions in gut and brain that create infarction. Acrodermatitis chronic atrophicans is years after a tick bite. From chronic borreliosis, you get areas of atrophic skin that may correspond to where you had an initial erythema chronica migrans, but then you get on your acral arms and legs, you get very atrophic skin as well. And it's a manifestation that was first described in people who are returning as prisoners of war, who had been sort of in Central and Eastern Europe as prisoners of war. And it was in patterns, so it was clearly something infectious that they had picked up. At first they thought maybe viral, but it's related to areas where Ixodes ticks were common, and they acquired the spirochete because of heavy tick infestation and exposure.
It's the color of like the pile of my trachoma, but I don't think that's what it is.
So kind of broad ulceration. And if this is all the ulcer, what's all this stuff that's vertically oriented within the ulcer? Collagen. So what kind of an ulcer spits out vertically oriented collagen?
Perforating calcific.
Not so much the calcific, but reactive perforating collagen. So reactive perforating collagen comes in two forms. There's the autosomal dominant inherited, where everyone in your family, wherever they get a blood draw, they get this little core that perforates out after the minor trauma. And you also get the acquired perforating disorder of renal disease, which tends to be an RPC pattern in people with chronic renal failure and pruritus and scratching.
So, another little ulceration.
Another little ulceration. What's under the ulcer?
Maybe some like granulation tissue.
Well, there's certainly granulation tissue to the side, but what's this intensely staining stuff?
Fibrin.
Fibrin. So ulcer with underlying fibrin and granulation tissue flanking it on either side.
Like CNH of this one.
like CNH, but I don't see cartilage.
It still could be it.
Yep, and if the biopsy was done well, it probably would not have cartilage, right?
Okay. Yeah, it looks like we have a perforating disorder of some sort.
Perforating disorder.
There's some aching.
And is the channel straight or is it
No, it's
serpiginous?
pretty serpiginous.
It's pretty serpiginous,
like,
and is it collagen or is it altered elastic that
more
is
like, oh, that's pretty, more like elastic.
like altered elastic fibers that turn red and are spit out through a serpiginous channel? So do you know any kind of elastosis that's perforans and serpiginosa?
More like that. EPS or
So
elastic
EPS, and where does EPS tend to occur?
The neck.
And it's often agglutinated papules, or sometimes in a serpiginous array on the neck as well. So the serpiginosa refers both to the histologic appearance and the clinical appearance, but they can just be agglutinated group papules on the sides of the neck as well.
Dr. Alston, we were talking, wondering if you do a trichrome,
Yes.
collagen's going to be blue. What color is the elastin going to be?
So elastin is variable. It's usually not picking up at all in a
Okay.
trichrome, which is why we do things like modified trichromes or Movat pentachrome that include an elastic stain.
Gotcha.
So usually you don't see it at all
Okay.
in the elastic. So okay. So let's go ahead and do this.
Okay, so it's a big, deep excision,
Yep.
and
And you think it's more like skin or mucosa?
that looks like mucosa, I would say.
And what kind of areas would mucosa have lots of striated muscle?
Maybe genital.
Or that would be smooth muscle.
Oral,
So oral, exactly. So oropharyngeal is where you have mucosa
Yeah.
with striated muscle.
And then there is something in the epidermis, it's like lichenoid maybe.
Yeah, so there is some interface change in the epidermis. There's vascular ectasia. And then tell me about the fibroblasts.
Yeah, ugly.
Yeah, very radiation-like fibroblasts. And this is from someone who had radiation for a tongue squamous cell carcinoma. And this is actually laryngeal tissue. But, you know, it's radiation dermatitis and oropharyngeal after radiation for a cancer.
Punch biopsy. Is it morphia again?
So, you know, could certainly be morphia profunda, given the deep sclerosis. And there's also sclerosis superficial as well, which could be morphia.
But I see some pigment incontinence.
Lots of pigment incontinence suggesting that there was interface dermatitis, which you don't usually get in morphia, right?
Yeah.
So you have features very much like morphia, but some things against morphia. Do you think this was radiation?
Not really.
Probably not. There's no elastosis, there are no radiation fibroblasts, and they're retained adnexal structures, right?
Yeah.
So probably not radiation. How about lichen sclerosis with the deep sclerosis?
Maybe. I think
Although, do you tend to get deep
Yeah.
sclerosis in LS? Probably not,
No.
right? So it doesn't look like radiation, it doesn't look like morphia, and it doesn't look like lichen sclerosis, but it's something sclerosing, because this was a patient with graft versus host disease and late sclerodermoid GVH, right? So GVH can have an interface phase and then the sclerotic phase, and you could go through this and kind of pick it apart and say, well, probably not radiation because of the retained adnexal structures and the lack of elastosis and radiation fibroblasts and ectasia. Probably not morphia because of the prominence of the interface change. Probably not LS because of the deep sclerosis. So you go looking for the clinical and something different.
Radiation.
So why radiation?
So you have the ectasia, the elastosis. You don't see good adnexal structures.
So for all those reasons, I agree with you. And how about this one?
Okay, extrudiform.
Extrudiform. So it's an extrudiform process. I agree.
Narrow channel.
Narrow channel and what's being
Yes.
spit out. Probably altered elastic. You can see the little fractile there. So, elastosis perforantia progenosa. Okay, name all the conditions associated with EPS.
It's just like it's crap moped. Cutis laxa, Rothman-Thompson, acrogerria, penicillamine, Marfan's, OI, PXE, errors down the stem down.
So it's good to have a mnemonic of some sort so you don't leave something out and it reminds you what things you have to look for. Okay, and one last one before we move to potpourri. So what do you see here?
I don't know if that's keloidal collagen or just hypertrophic scar.
Yeah, exactly. So we don't really see keloidal collagen, or maybe just the earliest hint of keloidal collagen. So this is hypertrophic scar with the whorls of myofibroblasts, and then maybe early keloid collagen. Very good.
That's a good box.
That is a good box. They're all good boxes. Okay, so let us switch to the wonderful world of potpourri. That's probably a good one to start with.
So it looks like I think if there's maybe some ghost cells in there, maybe pilomatricoma.
So it certainly rolls and scrolls. And so pilomatricoma, if these were basaloid cells that were keratinizing as ghost cells, are they basaloid cells keratinizing as ghost cells, or are they squamous cells undergoing abrupt keratinization?
They're squamous cells undergoing abrupt
So this is
proliferating pilar.
proliferating pilar cyst. Very good. Same architecture, different cell type.
Lots of hyperkeratosis with looks like grains in them.
Okay. So blue granules and hyperkeratosis. So do you know any form of granular parakeratosis?
It's like granular parakeratosis.
This is granular parakeratosis. Very good.
So it's probably spindle cell proliferation, and
And is it smoothly circumscribed, or does it have sort of a spiky pinwheel periphery?
I think it's kind of well circumscribed.
Well, I'd say
Maybe
these
a
are kind
little
of
bit.
pinwheel. Yeah, a little bit pinwheely.
And I was thinking about dermatomyositis. Fibroma, maybe?
So dermatomyofibroma or leiomyoma.
leiomyoma.
So in a dermatomyofibroma, you would expect that your
Yeah.
adnexal structure would be gone or preserved.
Preserved.
Preserved because DMF doesn't move follicles, right? So DMF doesn't move follicles. That's a Tyler Volkmar mnemonic. You have in this case, crisscross fascicles cut at various angles. Is that a good DMF, or is DMF more east-west?
I think it's more east-west, so it's more like parallel.
So this is more like piloleiomyoma, and then for confirmation, you look at your cross sections and look to see is there a little glycogen snack next to each of the nuclei, and there are little glycogen vacuoles. So piloleiomyoma, this is a patient with multiple renal adenocarcinoma. So that goes with fumarate hydratase deficiency and Reed syndrome.
Is there any squamous eddies
There are squamous eddies
and pseudohorses,
and pseudohorn
So
cysts
maybe-
and spindling of keratinocytes.
irritated SK?
So an irritated seb, what's the difference between an irritated and an inflamed seb?
Uh,
Inflamed seb has lymphocytes, right? Inflammatory cells. Whereas an irritated seb is like what happens when you put croton oil on a seb. It turns red, it gets squamous eddies, it gets spindling of keratinocytes, but there are really no inflammatory cells. And then you can have both. You can have one that's both irritated and inflamed.
Right, so there's some hyperkeratosis, which is over the epi, folded over a little bit.
And unfortunately folded a little.
That's okay. And then there's some inflammation superficially in the dermis.
Yep.
Let's see. It's not particularly chewing up anything. Are those nests?
Not nests, but lymphocytes.
Okay. So if they're climbing up, maybe some MF-like features.
Yeah, so maybe some MF-like features, especially because there's papillodermal fibrosis.
Yeah.
Now look at the vessel. Is there a bare underbelly sign, or is there plenty of lymphocytes? Are there plenty of lymphocytes under the vessel?
I mean, they're kind of circumferential, so there are some underneath.
Yeah, so it's not particularly a bare underbelly sign. So now I'm confused, right? Because you have some interface dermatitis. I would have said it is more like a lymph in every hole, right? Like an MF.
Sure.
And there's papillodermal fibrosis, but
Sure.
we certainly don't have the bare underbelly, and there's really no atypia of those lymphocytes.
Right.
So now I go to the clinical, and the clinical is that this is kind of violaceous erythema restricted to the knuckle areas on the hands, and someone who has similar violaceous erythema around the eyes,
Like dermatomyositis.
like dermatomyositis. So again, you clinical. Every case is clinical pathologic correlation, right?
Very pale, staining, lots of space between the collagen
Very pale, lots of space.
bundles. Looks like a lot of deaths in the epidermis, maybe
There is no epidermis. There's a capsule
the capsule.
in this very pale staining
Schwannoma.
thing. So schwannoma would be a good thought. You know, this could be a schwannoma. It is kind of oval, not particularly round. The other thing it could be is an intradermal or an intraneural neurofibroma. And probably the best way to tell them apart would be a neurofilament stain. And this had little crisscross neurofilaments through the whole thing. That favors which of the two?
The latter.
The intraneural neurofibroma, whereas a schwannoma wouldn't have that.
Let's see. So, sun-damaged skin,
Yep.
acanthosis, and then cystic-like structure.
So you have a dilated infundibular, like cystic structure, and in fact several of them, just some bigger than the others.
Over shock.
And then what do you have here?
Acanthosis.
Yeah,
Which I did.
kind of looks like follicular infundibulum, but it hangs like garlands hanging from the surface.
Tumor follicular infundibulum.
This is tumor of the follicular infundibulum. Correct.
That was easy.
Well done.
like the horn is acute, so probably more like an EMSJS.
So like an EMSJS. What's that structure right there?
Oh, hair follicle.
Yeah, hair. Does EMSJS usually necrose the hair follicle?
No. So
And
more,
is this purely lymphoid, or is it kind of mixed with neutrophils and neutrophil debris?
more mixed with that
And are these cells normal, or do they show ballooning degeneration?
ballooning degeneration.
So what causes acute necrosis, beats on the follicle, has a mixed infiltrate and ballooning degeneration?
VZV.
Yep. Zoster. Acute zoster.
Yay!
That was easy.
That definitely qualifies, and you get to hit it yourself.
That was easy.
This one struggles sometimes.
I think what we need is a new battery.
I agree. We can mark on that.
Okay. We have, it just takes a regular
Oh, perfect.
battery. We have them in the.
Yeah, in the
if someone
office.
wants to throw a new battery in there.
You got it.
Can.
It's almost like crack-like spaces.
Almost like crack-like spaces. No one ever wants to commit. It's almost like, it's sort of like, it's just about.
Like,
Yes, they're crack-like spaces. Okay, so the crack-like spaces lined by hyperchromatic cells. So this is
angiosarcoma.
angiosarcoma. Very good.
Oh, very good.
Not a very nice thing, but important to identify, right?
One as a proliferating pilar.
Like a proliferating pilar, except that this one
maybe-
metastasized.
No.
And so, what's the difference between proliferating pilar cyst and malignant proliferating pilar tumor that metastasizes?
Atypia.
Is the atypia, right? So unfair that I only showed you the bland portions of the proliferating pilar cyst. There are portions that are anything but bland in this tumor. And so if there's an infiltrative border or high-grade atypia within a proliferating pilar cyst, it's no longer a benign proliferating pilar cyst and is capable of metastasis.
Looks like an adult myofibroma.
So sort of like an adult myofibroma, except do you have hypocellular bluish areas in the cores of the nodules? Or are they uniformly cellular throughout?
Looks like uniform.
Okay, so that doesn't really fit for myofibroma, which should have distinctly hypocellular bluish centers.
Yeah, two cellular. Maybe neurothelioma.
Um,
Can it be
Cellular.
just fibromatosis?
yeah.
Yeah.
You see the corkscrew myofibroblasts when you put down your condenser. You see the collagen is corkscrew as well, right? So that goes with myofibroblastic. And nodules, really well-defined nodules of fibromatosis like this, would be typically what location? Usually,
Palmar.
or sole.
Lung.
The palmar tends to be more linear contraction, whereas on the sole in Lederho's disease, you get real nodules. So this
the
would
name of the one
be more
of the-
typical
of
of,
the abdomen?
like a desmoid, you mean?
Oh yeah. It will be
Yeah,
the same,
probably
right?
not desmoid, because desmoids are more uniformly cellular
But it
throughout.
looks the same, right?
Yeah, I mean, it fits within the spectrum of fibromatosis. Some consider desmoid to be a super, super low-grade fibrosarcoma because they tend to be more progressive.
Alrighty. So, looks like we have. Okay, I thought that was dead, but it's just, once again, looks like there's hyperkeratosis overlying some of the
So
skin.
hyperkeratosis.
Is that? It's not a poro.
So you are correct in that is not a
Thank
poro.
goodness.
So tell me why it is not a poro.
It doesn't have that 40-degree angle with the para.
And
coming
what
out
should,
of it.
and what should be at the base of porokeratosis? should be bright red, dead red keratinocytes, right? Here, what do you have? With a nucleus and a blue ring, and then a clear ring around that, and another blue ring.
Is that, yeah, like Grover's or
Yeah, acantholytic dyskeratosis, and this, if this is a solitary lesion, it's a warty dyskeratoma.
That kind of, it's gonna be like stasis.
So
Cannibal angioplasia.
there is a nodular angioplasia in stasis. Is it of thick-walled vessels or very thin-walled vessels?
Like thin wall.
Thin-walled but hyalinized vessels. This is a thick muscular wall, but then they're also thin-walled. They're thick and thin here.
That's it right down there.
So
So thick and thin walls, maybe, like an AVM.
yeah, exactly. So arteriovenous malformation, arteriovenous hemangioma, whichever you want to call it. Most actually are true traumatic AVMs.
Right. Superficial inflammatory infiltrate and then some tight.
Just superficial or
perivascular.
superficial and deep?
Superficial and deep around the vessels.
Okay. And then lumen to the vessel?
Can't see them.
What are all those big plump gray cells? Where the lumen ought to be probably
Histiocytes.
swollen endothelial cells, right? So swollen endothelial cells, tight, perivascular, lymphoid infiltrate, any other kind of cells present?
EOs.
EOs, so you're favoring what for this?
Angiolymphoid.
So does that tend to give endothelial
No, that would
swelling
be
with
hobnail-
occlusion or hobnailing?
hobnailing. So manipulates.
Anyone want to jump in? Yeah. So I heard both bite and arthropod. Which one do we tend to say in sign out?
Bite.
No, we tend to say.
Well, you
I-
write down.
Well, we write
arthropod.
bite, but what is
We don't say
it?
bite, but we know it could be a stick, right?
It could be a sting, but what else could it be? Could also be an infestation. This is a patient with scabies. Right? There, you got it right there. Right. So arthropod reaction can be bite, sting, or infestation, which is why we're always careful to say arthropod reaction in sign out, right? Because in this case, just at the edge of one of the halves of the punch, you see the popped eggs of the scabies. Otherwise, it looks like a bite, right? But we don't say bite, we say arthropod because it could be bite, could be sting, could be infestation.
So there's hyperkeratosis, some acanthosis.
It's all this little white stuff with prominent intracellular bridges.
Some spongiosis.
Yeah, so it's a little bit of low-grade sponge. What are these guys?
Some EOs.
What are those guys?
Lumps.
What are those guys?
Red blood cells.
Red blood cells. So there's erythrocyte extravasation in a low-grade spongiotic dermatitis. So give me at least two things that will give you erythrocyte extravasation within a low-grade spongiotic dermatitis.
PR or PPD.
So either pityriasis rosea or Ducus capnonicus type of pigmenting purpura. Very good. How are we doing time-wise? We've got about 10 more minutes, right?
Lots of blue cells in the dermis. They look pretty nasty. Like Merkel cell.
Yeah, kind of smudged,
Yeah.
hyperchromatic, Merkel-y blue. There are other small cell tumors, everything from lymphoma to small cell endocrine, neuroblastoma. The one that tends to form these wall-like parallel theques, reminiscent of trabecular bone, is so-called trabecular carcinoma, which is the old name for Merkel. And that's, you still end up doing immunostains, but you can be pretty sure when you see that pattern, and that's much more common in Merkel than in other things in the differential, that trabecular pattern of growth.
Which is stratum corneum.
So stratum corneum with perikeratosis, and then we have some underlying. Myrmecia with the red inclusion bodies in the wort. So Myrmecia meaning anthill, referring to the anthill-like morphology of the lesion clinically. What kind of basal cell? Has strands like that radiate outward.
Infundibulocystic.
Like an infundibulocystic, but there are no cysts. It's still infundibulocystic. You don't always see the cysts. So you are correct. So in this case, an infundibulo, not so cystic, right?
You have big nodule.
Big nodule.
Tract collagen.
And what are the color of the cells?
Purple.
Yeah, kind of like everything that Barbie owned, right?
Oh my goodness. Yes. Is it granular?
It's a granular cell tumor from scan based on the color, right? Beautiful. So for the guys in the group, if you don't have a daughter, go out, find someone who does, and look at what Barbie owns and the color, because that's about the color of a granular cell tumor. And then if you go higher, you will see the giant lysosomal granules that are diagnostic, right? For a neural type granular cell tumor. The non-neural granular cell tumors tend not to have those particular giant lysosomal granules. Okay, how about this?
An oblique cuts and acanthosis.
Tell me about the corneum.
Punch full of holes.
Punch full of holes, and then your epidermis.
Viral change. Lacking or
So this is probably what? What type? Probably verruca plana. With the corneum punch full of holes, very coarse basket weave, would be typical for a flatwort.
It tends to infiltrate in the dermis.
So it's a dense lymphoid band, so this is lichen sclerosis, right? Do you see homogenized collagen?
No.
What are those gray cells in with the black lymphocytes?
Histiocytes or melanocytes?
So what if they were melanocytes?
Worried about like a regressed melanoma.
Or so are these lymphocytes intimately mixing with the gray cells, or are they walling them off?
They look like they're mixing.
So this is more like a pattern of a,
Just a regressed nevus.
or halo. Yeah, halo nevus, which is an inflammatory regression of a nevus. We don't use the word regression just because everyone thinks melanoma when you say the R word, right?
So, pretty square punch.
Pretty square punch.
It's pretty, looks like homogenized more toward the top of the dermis. There are some lymphoid, or some inflammatory cells by lymphocytes.
Yeah, and so this is one where it's kind of hard to tell. Is it more like lymphoid nodules, or is it a sparse band, kind of undecided, right? So is all of this down here good for lichen sclerosis?
Well, not being so deep.
Probably not, right? I don't really see so much trapping of the adnexa there. There's plenty of fat remaining, but I still suspect morphia. Any kind of stain that you might do that might help if you're on the fence?
Like a CD34.
Like a CD34, which tends to be lost pretty early.
3. Let's see. We have some pigment
And where's the pigment?
above the vessel or around the vessel.
Around the vessel. So is this a recent or a later stage pigment loss?
Looks like a later stage.
Yeah, it's had time to take the crosstown bus, right? So it's all the way down by the vessels. So, could it be a late stage of fixed drug? Possibly.
Mm-hmm.
You have some interface active, but it's not, I don't see a polymorphous infiltrate like you'd expect in fixed drug, right? So if this is a South Asian female who's turning gray, ashy,
Like an ashy dermatosis.
an ashy dermatosis, so erythema dischromicum perstans.
So it's a dermal nodule
Dermal nodule.
and then angiola.
So angiolymyoma, you have vascular lumen, you have a muscular wall, and then the muscular wall never ends. It becomes the tumor, and the whole thing's like a red marble down in the dermis or subq. So angiolymyoma, very good. Let's see what else we have to do. Any time remaining?
Dense infiltrate looks like granulomatous process.
So granulomatous process dense infiltrate, give me a differential. First off, are these granulomas, do they have a pronounced round cell lymphoid infiltrate around them, or are they pretty naked?
Pretty naked.
Pretty naked, so
So sarcoid.
sarcoidal granulomas. So other than sarcoidosis, what else produces sarcoidal granulomas?
Leprosy.
So leprosy can do sarcoidal granulomas, so that's in your differential. What else? Crohn's disease.
Crohn's disease.
So if it's in the genitalia or leg or perioral, perianal, those are all places where you could see Crohn's. Zirconium and beryllium granulomas can be sarcoidal, and then silica granuloma, which is scar sarcoid. And with that, we will stop. Very good.
Thank you.
Thank you.